So let's move on more with the physical therapy examination intervention of the abdomen. So one of the things we want to do is look at the whole person and not really be as regional specific, because there could be drivers coming from other areas. So we want to look at posture. Are they ligament leaning? Are they stooped? One of the things that I look for is not as if it's a bad or a good posture, but what's the dominant posture? Because it's the dominant posture that we probably need to change. And it's not so much changing it, but giving them variance around that dominant posture. And what happens when we do change the posture? Does it change their symptoms in any way? Are they worse when we actually load them in postural standing or postural sitting? Want to definitely do a neuroscan. We just talked about that and the importance of that. Upper motor neuron, lower motor neuron. If we're looking at lower motor neuron, we're looking at spinal stenosis in the lumbar spine, radiculopathy, neural compression versus inflammation, so posterior lateral nerve roots, things like that. That can be part of what's going on. Spinal motion is important to just look at flexion, extension, side bending in the lumbar spine and the thoracic spine, add in the rotation. One of the things that I think is really helpful is looking at thoracolumbar junction, area of counter rotation between the lumbar spine and the thoracic spine. Remember, T11 through L2 is where a lot of neurology for the visceral organs come from, particularly in the GI system. We want to, next slide, we want to continue on with general strength, core muscle activation. Can they turn those muscles on? Can they bring them on when they need them to come on? Do they happen automatically? Are they overcooking their abs by really pulling their abdominal tone in really hard, becoming abdominal grippers? What kind of myofascial restrictions do they have? Do they have restrictions in their abdominal wall? Do they have restrictions in and around, organ mobility? Is the abdominal tone hard or is it soft? Do they have pain, tender points? Is the Carnett sign positive for visceral pain or for abdominal wall pain? Careful examination of the abdomen, perineum, and the anal rectal region is very important. So you want to put all that together as you're looking at the pelvic region that we did before. In the abdomen, you're going to palpate for stool, hard restricted tissues, scar tissue, pliability, mobility, and motility of the viscera. The perineum, you're going to be looking at visual for patulous anuses, scars, skin, excoriation, prolapsing hemorrhoids, skin tags, or fissure, just like we talked about before. When we're looking at the respiratory, we're going to be looking at, does the diaphragm move? Do they have basilar rib motion? What's happening there? What does their breathing look like at rest? What does it look like when they're exerting a little bit more? Remember, with primary respiratory muscles, the diaphragm is the one, and its job is to increase the negative pressures in the chest to draw the air in by descending, and then it returns the airflow out. And the other important thing is the diaphragm with the abdominal muscles and pelvic floor work very hard to clear the airways for coughs and sneezes. We want the inspiration and expiration to just match the demands of the activity. Are they really breathing hard just sitting? Or are they really having to exert really hard to just get out of the chair or get off of bed? Why are they having to work so hard, and why are they breath holding or breathing so hard to do that? Phonation, what does it sound like from quiet talking to yelling really loud? Are they able to develop a very strong, loud voice, or does it start to crack and fade immediately? And remember that the diaphragm itself, too, is the primary mover of the internal organs. So if they're breath holding or not using, not breathing with all of their muscles up high and not really letting their diaphragm do the work of being the primary respiratory muscle because they're asking it to be a postural control muscle, we're not getting great movement of the internal organs like we should be getting. So we really want to keep that in mind, and that's why we really look at breathing and changes in breathing. This is just a picture to remind you that we have pump handle breathing and bucket handle breathing. So the pump handle breathing is the ribs coming up and down in the front, the high ribs, and the bucket handle is the ribs going out to the side and up and down as you see them move that way. Faulty breathing patterns, there are some consequences to that. We can get changes in the respiratory chemistry and in the pH levels in the body. So if we're breathing high and hard like we are exerting or running from the saber-toothed tiger, we're in definitely much more of an acidic state. And remember, the small intestine and the GI system like to work much more in an alkaline state. So when we're in an acidic state, that chemistry tells them to shut down. And it's not a good time for them to be working, that we need to have this other chemistry so that we can escape. So this is going to trigger smooth muscle constriction. That makes sense. We don't want the GI on when we're trying to survive. It changes electrolyte imbalance. It causes decreased tissue oxygenation over time, and then an increased excitability of the nervous system and the muscles. So some systems are not going to get the oxygen. The muscles and the nervous system are going to get super excited. So we get twitchy, and if we don't know how to turn that system off, we stay pretty twitchy. Musculoskeletal and fascial support is important to understand too, because we have to remember that the abdomen is in a visceral water balloon, so that all those organs are sitting inside that balloon. When we have problems with prolapse and scar restrictions and myofascial restrictions, we want to also consider that musculoskeletal fascial support, because it may not be working as optimally as possible. When we have surgery to the area, and that can even include C-sections, hysterectomies, gallbladders, endometriosis surgery, all of the above, and anything else too, colon resections, all kinds of things, all of those are going to have effects on how the abdominal wall and the abdominal cavity is going to heal and is going to move.